support group for new nurses starting out in the field, in the clinical setting, and for nurses who would get easily overwhelmed because there's just so much going on, um, as the work of a nurse is supposed to be. Tonight's topic is about what is the most important part of your patient. Now, I'm not, of course, there are so many parts of the patient. There's so many of the patient that is important, right? Even the patient themselves is important. But what I'm trying to emphasize tonight is what to look out for specifically, all right? So this is the usual setting. When you go to your first duty, or when you start your shift, right? You walk into the floor and everything is just so busy. There's so much going on. A lot of people, family members, significant others. Maybe there's new patients, so many monitors and alarms going on. And you could easily get overwhelmed and get lost. And imagine that that's the start of your shift, right? Imagine how you were hoping for an easy shift, but then boop, you were greeted with all of this stimulation. And what our mind tends to do for our mind to cope during overstimulation is it's gonna try to simplify or oversimplify so that everything would seem manageable. Although, as you know, as a nurse and in the nursing field, you can only control things to a certain extent. You can only manage things to a certain extent. The rest is really up to the universe and luck. All right, so I'm gonna go back to my point. So, back in the day when I worked as an intensive care nurse, I would have new nurses come in, and we would mentor them, and I would always secretly tell them that, to me, the most important part of your patient is the IV line. All right. So whenever you make your rounds, whenever we make our rounds after endorsement or before endorsement or before handover or report giving, we would do general rounds and you would see each patient. If you know your patient load and you see the patient, of course you scan your patient, see how they're doing, and you see attachments. In intensive care, that's a common thing too. Or actually, no, in the floor, we also take note during rounds the attachments, meaning what's connected to the patient. Do they have a urine catheter? Do they have IV lines? Are they connected to a nasal cannula? And what is the current doctor's orders for the oxygen level? Now, of course, nasal cannula, urine catheter, these are important attachments to your patient. But to me, secretly, I would say, look at the IV line, look at the IV dressing. Make sure when you make your rounds, look for it if they have one, and then make sure that the dressing is either intact or you reinforce it, you support it, okay? And to me, the reason why that is the most important part of the patient is because that's where we give our medications. That's where you give emergency medications during an emergency. Most often than not, your patients have IV medications, antibiotics, IV antibiotics, and they have to be given in a timely manner. Because um, if you don't, its effect will be delayed. With IV antibiotics, you can prevent sepsis, infection in the blood. You can also lessen pain caused by certain infections, like amoebiasis. And sometimes or half of the time, it's not easy to find, good veins for IV access. Good if you're lucky, if you've got a PICC line or an IJ cath, fine. But if it's just IV line, you really have to look for it and make sure that it is reinforced and, you know, working well. So that is what I want to encourage you and to really focus on when you do your rounds, when you see your patients. Like if you have like a 10 patient load and you're like, oh my God, there's just so much going on. Like you enter the patient's room, you enter the patient's bay, right? There's so much screens and supplies. Start with the IV line. Start with what's connected to the IV line, right? Start by looking at making sure that whatever is connected to the IV line, there's enough fluids, there's the backup. If you're in the ICU or in any critical care areas, if they're connected to these medications, these inotropes, make sure that you've got your backup, of course, according to the facility's policy. Okay, so IV line is your most important part of the patient. Also, it also delivers hydration in case, you know, patients are having issues with their blood pressure or low urine output. It's really very important to make sure your IV line is working. Okay, if you disagree or if you have other thoughts or opinions about this, please write them on the comments down below once this video is saved. I know that I usually do these live sessions at 9 p.m. New York Eastern Time, but I have been away for the last 2 days because I haven't been feeling well. Turns out that I underate. I did a road trip the other day, and I hate it and I rent cars because I live in New York, so I don't keep a car. And I hate it how cars are not automatically set for air to be just circulated within the car. Because when I'm driving in the highway, when I'm driving through the bridge or tunnels, and the exhaust is open to the outside air, I am breathing in fumes from other cars. And I noticed as I started getting a headache. And um, that's why I'm like, I wasn't able to go online for the last 2 nights because I just had a headache. All right. And just to wrap things up, I know that these sessions are supposed to be 20 minutes or 50 minutes long, but I am past my bedtime. And my topic for tonight is actually very simple. IV line is the most important part of your patient, okay? Make sure it's reinforced, the dressing is reinforced, add a tape every time you see your patient. Of course, you have to cluster in everything that you need to do with that patient, and that will always include checking their IV site and making sure it's reinforced and that the condition of the skin is fine, okay? Because there have been many lawsuits of infiltration and other issues when it comes to the IV site. All right, and then I just thought of just talking about my work history as a nurse in these videos. So I graduated 2008 March. I took the Philippine board exam to be a nurse in November 2008. I took the NCLEX RN in 2009. I tried to do job searching, and then I got my first hospital job 2010, around 2010 March. And you might think why it took so long. That's because it's not easy, it's not quick to get a hospital job, especially a proper hospital job. In 2010, I did get my first job in a large hospital, 500 bed capacity, Joint Commission hospital in the Philippines. I was in a medical surgical ward with an isolation wing. I got overwhelmed. I think my orientation was for 2 months, and then we were set to our areas. We do not get to choose our areas. The hospital chooses for us, and back in the Philippines. So I thought I was confident. I got overwhelmed because I just like, oh, I was so scared. Like, oh my God, what if I make a mistake? And these videos really I dedicate to people who go through what I went through, who are scared, who feel overwhelmed about working in the floor. And I'm just here to be your coach, to be someone to mentor you and to guide you and to share my tips. Because so in 2010, I think March, I quit after being on the floor for a week or two because I got overwhelmed. And then I worked in in a school that taught English to second language speakers. I did it for over 2 years, and then I went back to the hospital 2013. 2013, same hospital. And I was in a medical surgical floor with a pedia overflow. And then this time, I had the courage to apply for ICU in that hospital. And usually nurses don't apply for the ICU because it's such a difficult, tough area. Usually people are forced to go to the ICU, but I was a part of the 5% that actually applied for it. And the reason why I applied for it was because I wanted to work in the States, and I've learned that if you want to work in the States or abroad, you have to have a mind of like a doctor. You have to think like a doctor. Although you still have to think critically in the floor, but remember your patients aren't as critical as, in the intensive care. So I did apply. And then I left the hospital 2012. I left, I think somewhere, was it 2014? No. I left, what I do know is I left for London 2016. And before I left London, I think I worked for maybe 9 months or a year doing utilization nursing and nurse first response in the Philippines, but that was for a US account. And in nurse first response, I got to do telephone triage for more occupational health, for work related injuries. Utilization review, I did that too. And then in London, I worked in a trauma center. I worked in a cardiothoracic unit. I worked ultimately at the cardiac recovery unit where we would receive patients having heart surgery or cardiothoracic surgery. They are critical patients. We were considered level 3. And then because I wanted to get more money, I applied for in London for the private sector to work as a disability analyst. As a disability analyst, what you do is you just interview and you assess people who are applying for benefits. And we don't make decisions, FYI. There is a formula to it and fixed questions that the government expect us to ask. I did it for 6 months because within 6 months you have to be certified. To be certified is you have to have A1 scores for 5 reports in a row, and I wasn't able to meet that requirement on time, so I wasn't able to continue. And when that didn't work out, I decided, okay, I'm gonna move to the States. And to prepare myself for the States, I worked in a nursing home. And when I moved here to New York, I worked in a nursing home too. And then finally, I did school nursing. But that's a story for another time. All this to say is that I've worn many hats in different fields of nursing, and I just want to pay it back to those who are following along this journey. And I just want to be present for you guys if you need it. And if you don't need it, then this is the wrong channel, wrong video for you. But if you do need it, if you think you know someone who would need this support and who have questions or who just want to spend time to connect, this is the space for you, and I welcome you. So thank you for watching. And the IV is the most important part of your patient. Remember that from Daniel. There's Daniel. And I will see you tomorrow, hopefully 9 o'clock. If not, well, I might be going out tomorrow, so I might not see you at 9 o'clock, but I'll do try to make a recording. All right, so thanks for watching. I hope you have a wonderful rest of your week and a nice weekend ahead. All right, let's see, what does this mean? Ooh. All right, bye guys, good night.